Thank you for joining me for today's lecture on health inequalities under COVID. Today we are examining why people from different genders, races, and classes can face different COVID infection rates and mortality rates once infected. Joining me today is Dr. Lindsay Richardson. Dr. Richardson is a professor of sociology at the University of British Columbia and a research scientist at the BC Centre on Substance Use. I've invited Dr. Richardson to speak to us about traditional ways disease has been approached and why a sociological lens can help healthcare providers and the general public in combating COVID-19. Professor Richardson is going to evaluate leading theories explaining differences in health outcomes under COVID by race, gender, and socioeconomic status. For gender, Dr. Richardson will explain why more men than women have severe symptoms and die from COVID. For race, she will consider the types of COVID health data being collected and why a lack of race-based data is a pressing issue. For socioeconomic status, Dr. Richardson will ask how a person's income and wealth affect their access to preventative COVID measures, as well as how class informs the pre-existing conditions a person might have that will increase their risk of severe COVID-19 symptoms. Dr. Richardson will finish off today's session with a case study of how the pandemic is exacerbating the opioid crisis in British Columbia, Canada. First, I offer a few key ideas that will be useful in interpreting Dr. Richardson's lecture. Think for a minute about what health is. What does it mean to be healthy? If you like, pause this video for a moment and enter your description of health in the word cloud below. The World Health Organization states that being healthy doesn't just mean you're illness-free. To be healthy is to be in a state of complete mental, social, and physical well-being. Health is more than our biology and operates at more than just the individual level. Our health is tied to broader population health, healthcare institutions, and health inequalities in society. Fundamentally, sociologists aim to look beyond the symptom level of illness and treat the root cause of health inequalities. Focusing on these root causes is known as a social determinants of health perspective. The World Health Organization defines the social determinants of health as the conditions in which people are born, grow, live, work, and age. Let's take an example from the COVID context. We can see the social determinants of health shaping COVID risk at elder care facilities. As Dr. Anne Martin Matthews will discuss next week in her lecture on COVID ageism, the rapid spread at elder care facilities was perpetuated by the funding model of these facilities and the lack of government regulation and oversight tied to ageism. For example, some facilities had been operating for years with too many beds in a room. When COVID hit, its rapid spread was built into the design of these facilities. Cost-cutting measures also meant that many care workers and health workers at these facilities were part-time and contractual, meaning that they had to work at multiple care facilities to support themselves rather than having a stable and well-paying job at just one facility. As these care workers moved between facilities, so did the virus. Social determinants of health are often organized by social group. In the previous example, we see that while age as a biological category may make people more vulnerable to experiencing severe symptoms of COVID once they come in contact with the virus, it is actually how societies perceive age and structure elder care that created the higher risk of infection for older adults in care. Let's turn now to Dr. Richardson's analysis of key social determinants of health under COVID-19.